Okay, welcome. Thanks for being here, everybody. If you're live, we'd love to hear from you. If you hit the replay, love to hear from you. #replay. This is Dr. Sarah Merritt of Lifestream Health Center in Bowie, Maryland, and we are working to make pain management care more caring, accessible, patient-centric, and evidence-based. And so we are here to educate the community and help people with significant pain problems to have better health literacy and so they can feel better. And fortunately, I have a lot of friends that want to do the same. And so today we have the one and only Dr. Arinola Dada of Overlake Arthritis. And I'd love to have you introduce yourself.
Okay, thank you, Sarah. I've been listening to your interviews the last few days, and I actually learned a lot. I think this morning I was listening to the one you guys were talking about chronic pain and depression.
Oh, yeah.
That was a really good one. So my name is Dr. Arinola Dada. I help people with autoimmune diseases get their immune system back on track, and I help people dealing with joint pain become pain-free. I have a rheumatology practice in the greater Seattle area. And most people want to know what a rheumatologist is, and we basically do a lot of work with people with arthritis, joint pains, and autoimmune disorders.
Excellent. Yeah, and so the work that a rheumatologist does, I would say, we refer patients to rheumatology from time to time. Maybe not every patient, but a lot of patients probably. The value that I see in it is often to rule out or evaluate, are there specific inflammatory conditions they might have? Tell me about that. Tell me about how a rheumatologist might dive into questions about what's causing a patient chronic pain.
Yeah. So, I think we, as a rheumatologist, when we see a patient, we're typically trying to figure out if the cause of the pain is due to the immune system being totally out of whack. I like to tell my patients that the immune system is supposed to be your protector. It's your military. You're a country. The immune system is your military. And so the job of the military is to protect you from invaders, whether they're foreign or domestic. So in the body, the foreign invaders are viruses and bacteria, fungi, and any of those things trying to get into you. And the internal invaders are more like cancers, right? So your immune system is there to protect you and keep you safe, right? But unfortunately, even the immune system can go completely wacko, and it's almost like a coup. So the immune system then something goes wrong, and the immune system then turns its guns on the body. And so in that case, we develop a whole bunch of autoimmune, so where the immune system is directed against itself. And then we now break them into different categories. So people know about lupus and rheumatoid arthritis and exotic things like scleroderma, psoriatic arthritis. All of those conditions are basically the immune system in some way or the other getting confused and thinking that our cells is an invader, and then it tries to attack it. So the rheumatologist is always thinking, is this more of a mechanical problem that's causing the pain? So patient played soccer, injured their knee. Is it more mechanical, or is it that the immune system got triggered and is then going down a different path? So we're always trying to separate those two baskets.
Yes, that's great. Thank you. That's a big overview because it's so important. And I like this idea of the immune system as the military, the enforcers, keeping us safe. Yeah, because I think otherwise, it's easy to, especially when I speak with patients who might have an autoimmune condition, it's easy to just think like, what good is this doing for us? But the immune system's doing good things for us all the time.
Oh yeah, well, yeah, without it, we don't exist really, because there's bacteria everywhere, all kinds of things trying to get at you, and the number of things that your body comes across every day, it's a miracle.
Yeah, right. It's a miracle that we can expose ourselves to uncooked foods and all kinds of things. And continue to live. Fantastic. So I know that, so refer patients to rheumatology sometimes to evaluate if there's a immunologic condition that's contributing or causing a person's pain. I understand that gout is one of the specific pathologies that a rheumatologist deals with that you're interested in. Tell us a little bit about gout. What is it, and how would a person come to be diagnosed with gout?
So, unlike the autoimmune diseases, gout is more like a failure in some process. Um, Eons ago, when we didn't have a lot of food to eat, when our primary focus was how to get food and keep it, we did not really have a high protein load, right? You probably find a chicken, your whole village finds a chicken once every 2 or 3 months, and it's a big party to have that. We have that just for snacks, right? And so now we're, because there's a surplus, right? Our body is not really programmed to be able to deal with the vast amount of protein that we're exposed to. We also are heavier than we used to be. And so over the centuries, now that we've been exposed to a rich king's diet, we then have a lot of purines, which is a breakdown product from protein, which back in the day was quite a luxury. And so now we have this breakdown product of proteins that become uric acid that we can't really excrete as easily. So men are more likely to get gout than women. It tends to be genetic. And so basically these crystals go and they sit in joints. And so when it presents acutely, it's more, I describe it as somebody came, smashed your foot with a hammer, go away, and come back and smash your foot with a hammer again. So it's very acute, it's intense. You don't want anybody touching it. You don't even want Dr. Dada touching it.
Yes.
That's when they come in acutely. And if it goes on for a long time, then it can be more of kind of the chronic gout.
Yeah, tell me about chronic gout. I had a patient recently who was having a lot of foot pain, and the patient did have gout in her history, but then she also had sciatica. And so in terms of understanding, well, what is making your foot hurt today? Sometimes it can be a little challenging.
You're certainly right. Definitely. I mean, because, the sciatica pain is low back pain that's radiating all the way down and can go straight into the foot. And you're right. When she's complaining, she's probably talking to you about this sharp pain. Right. But I always, I think listening to the story, and sometimes it doesn't show up on the story on the first day. All she knows is she has pain and get rid of it. Right. But I think it's when she comes back with the story of this acute, sudden pain that kind of eases off and then is back so aggressively. Right. But I totally agree that it can be hard to tease out, especially if she has both conditions. And because they're both describing pretty sharp pain, and I'm sure certain positions make her sciatica worse, but may not necessarily affect her gout. But I think when she's talking about a red swollen joint too, then that probably would sound a little different from what one would expect from sciatica. One of my pet peeves with gout, though, is that it is totally treatable. We don't have to suffer.
What?
It's totally treatable. It's totally treatable. But most people just kind of feel like, well, it's my gout, and I'm just going to take a little ibuprofen. But this thing just keeps accumulating and accumulating and damages joints. So I really feel like, I'm on a mission to let people know, hey, we can treat this thing. You do not have to suffer.
Yes.
Right?
And so if, that's great. And so like taking ibuprofen, the crystals will still, in gout, these purines seep into the joint. They make crystals, I think.
Yeah, they do, exactly. They make
and then
crystals.
They kind of can't get out, right? They're sort of trapped. That's the challenge.
Yeah, exactly.
So,
So
I was just going to ask, like, when they're trapped in there, what are the treatments? Is it medication? Is it an injection? Is it, dietary modification? What things do you recommend?
All of the above, right? So the first thing, I talk to patients about, so we're going a little bit into why it hurts,
Yeah.
And why it hurts intermittently, and then what we can do. And I usually try to tell my patients that so they understand when they're doing X, this is why they're doing it.
Mm-hmm.
And so the reason why it hurts is, so we've gotten to where we have too much protein, we're eating too much, we're living large like kings. We form this uric acid, and this uric acid sits in the joint. Well, when it sits in the joint, you have these white blood cells, and their job is to figure out if there's anything abnormal. So they're like regular patrol troops.
Okay.
And so they patrol. And when they see this crystal that doesn't belong in the joint, they're like, hey, call your friends. What's happening here? So that's when you get this acute attack, because your white cells come, they try to engulf the uric acid. They're not successful. They get more white cells, and it almost becomes like a storm, like a
and
fire.
it's even the inflammation that's so painful, right? And
it is actually.
This is like the body's response that's more painful than even the thing itself.
Exactly.
Oh my
because
gosh.
that's exactly right. It's the white cells that come and actually create the fire. Your uric acid crystal was sitting down there. Yes, a little bit of a nuisance, but it's when your body recognizes that, hey, we have something here that doesn't belong here. We're going to get rid of it. Right.
Yeah.
So it sends the white cells. The white cells try to swallow up the uric acid. They choke on it, and then they send more white cells. And then that is what causes that sensation of I got smashed, my foot got smashed with a hammer.
Yes.
So I think when we understand that, then we understand that, well, there are two issues. One is, what is the pain that is causing the patient to come in holding his shoe? And that's one pain. And then what do we do long term to protect the joints? So that's when you talked about, what can we do to protect the joints, is then we look at diet, right? Because I want to kind of prevent the future attacks.
Yes.
So, high fructose corn syrup is not good for anything. It's also not good for gout, right?
Oh.
So
it doesn't have any purines in it, though. There's no protein in high fructose.
It doesn't, but it's actually very interesting. Yeah, you're right. But that actually precipitates an increase in purine. You could say the same thing for beer too, actually, because that's number next on my list. Is that beer is a known catalyst.
Beer, okay.
Yeah. So and then shellfish.
Yes.
Yeah. So and then organ meats. Now, I like a delicacy or two, but if you have gout, you got to be careful with those innards, right?
Yeah.
So my favorite pitch is when I was at the VA. Our vets used to go fishing, and so they'll get a lot of shellfish, and they'll wash it down with beer.
Oh boy.
And Monday morning was gout clinic.
And everybody came up. Yeah.
And and they're like, yeah, it's that shellfish. I know it, Dr. Dada. I'm like, okay, let's find something else for you to have when you guys go fishing, right? So we try to differentiate kind of more the acute problem, which is when the anti-inflammatories come in, which is the eyes, and elevate your foot, right? And try not to put too much pressure. Talk to your doctor. They can give you medications like steroids and can do shots, things like that, to get rid of that inflammation, the acute problem. The issue is that most people, when the acute pain is gone, they're like, okay, it's gone, but it's not gone, right? You're still accumulating those uric acid, and it's still causing damage to your joints. So there are medications, in addition to diet, that we use to try to prevent your body from making any more of those crystals.
Okay.
So those are kind of the two, categories of how we address it.
Yes. So you start with diet and maybe see if those interventions can work.
Yes.
And then if the diet changes are not sufficient, then you might recommend trialing a medication.
Yes.
And the medications are what can help the body clear the crystals. Is that right? Or do we just need to tamp down the immune system?
So your immune system is not really the problem with gout. It's just you have something foreign there, and it's just a white blood cell reaction. So your immune system is actually fine. The problem is you just have these abnormal crystals. So the medications such as the allopurinol and the Uloric, they just stop you from making any more. They're like, stop digging. So stop making any more uric acid. And once you stop making any more uric acid, the crystals that you have in your joints just start to seep out just by diffusion, right? And so that's really how those two medications work. And then there's, for people who have large, massive amounts of uric acid sulfide, there are medications like called Krystexxa, which will actually melt away all the uric acid crystals in the joints.
And what's that one called?
Krystexxa, like Christmas, Krystexxa.
Very good. Wow. Yes. And so the tophi, right, or the accumulation, they're the accumulation of the crystals. I've seen these before where patients might have a big protrusion from a joint.
Yes, exactly.
Very good. And Krystexxa, what type of medication is that? Is that oral? Is it given IV?
Oh yeah, it's intravenous. So it's an intravenous medication given to people. Usually has to be in your rheumatologist office, or at least, or in your nephrologist, in your kidney specialist office. I think those are typically the people, because people with gout can also have kidney stones. Yeah, so it could get worse. Yeah.
Oh, wow.
So that's why the kidney specialist also may be treating that condition where you just have so much uric acid crystals that they're just everywhere.
What about the medication colchicine?
Yeah. So colchicine is one of the oldest medications that have been used to treat gout. And it's a miracle drug for us, right?
Yeah.
And so we use it for two major things. One, it actually helps. Remember those white cells we talk about running into the joints, trying to engulf the crystals? Colchicine actually stops them from moving in. Right? So you used to treat it kind of early at the beginning of the attack.
Yes.
And it also helps to prevent recurrences, right, of attacks. To some extent, it's not perfect, but it definitely makes a big difference. And especially for people who can't tolerate like high dose of steroids or anti-inflammatory medications, colchicine is very helpful. The one thing people don't like is the diarrhea.
Oh.
So yeah, nobody likes the diarrhea.
No.
So sometimes you kind of have to manage it. So I tell my patients, we're going to take as much colchicine as you can tolerate. Yeah.
Yes, and usually the patients take that medication just around the attacks. Is that right?
Yeah. So you can take it initially when you start. It's always easier. It's kind of like a fire, right? It's easier to just take the colchicine at the beginning of the attack, right? But once the attack fully sets in, then it's more difficult for colchicine alone to handle it.
Okay. That's helpful. That's helpful. Yeah, I know I certainly have patients that have that as one of their options when they have an attack. Very good. Well, thank you. That's super interesting. And really the IV medication is newer for me, but that's exciting to know that there are options if patients were not getting control of gout with these other measures.
Yeah, I mean the IV medicine is a game changer, I think, in the world of rheumatology right now.
Yes.
We typically would expect those lumps to take years and years, and now it's resolving in months.
Wow.
So I tell my patients, I think it's a benefit of technology, right? We benefit from technology, whether it's your cell phone, you can watch a movie on your cell phone, you can get rid of tophi in a couple of months. So I think it's a game changer for us in the world of rheumatology and gout. That's what gets your rheumatologist excited.
Yeah, yeah, no kidding, no kidding. When I think about gout, the other interesting gout case that I have seen in my training and practice was actually when I was a resident, and we had a patient on the floor who was admitted with some mysterious, very intense knee pain. And, spoiler alert, she actually had an acute attack of gout, had never had gout before, and it was presenting in this knee. And she had this massive effusion that I got to drain in her knee, and she felt so much better. Yeah, it was.
I think my one of our favorite patients actually was a software guy. And he had come into the clinic. He already knew he had gout. He wasn't here for the diagnosis. He already knew that because he'd been to multiple doctors lots of years. But his gout tophi was just in his hands, and it was so much that he was having trouble typing. You know, he
Oh,
was a software guy, and he told me, he said, "Am I going to have to go on disability because of
oh my
gout?"
goodness.
You know, and so he was one of the first few people years ago that we treated, and those tophi resolved, right?
Wow.
And so yeah, he was yeah, and he convinced us that, you know what, this is a miracle. Yeah, and this is some years ago, but yeah, he will never forget him.
Game changer. Yeah, no doubt. No doubt. And and patients are just so grateful when you can help in like a
When we can,
meaningful way
yeah,
like that.
I mean that's why I got into rheumatology, is, you know, because they have the option of helping people. So
Absolutely.
I'm making a difference.
Yeah, that's great. And so tell me a little about your practice. So in your location, you have services including IV infusions and seeing patients. Tell me what else that you have to offer. I think you have
Yeah,
some testing.
yeah, so we the two physicians, two nurse practitioners.
Hmm.
We have a full 10 chair infusion center,
Okay.
where actually other doctors also refer patients to us depending on the condition.
Hmm.
If they don't have access in their clinics, we have a bone density machine. So we're called Overlake Arthritis and Osteoporosis Center, and
Mm.
so we treat people with low bone density who are at
Hmm.
risk for osteoporosis. So we do the scan and everything in-house. We actually
Hmm.
have a lab. The lab actually is LabCorp, but they have a center here, and we provide it for our patients for convenience. So we try to make it a one-stop shop. So when you come in, you see your rheumatologist, you get your bone density test, you get your lab test done. You can also get your infusions done in the
Hmm.
clinic.
That's fantastic. That's fantastic. Um, yeah, so patients can come in, they would get potentially see the physician and be able to get their testing all in one place. That's great. And then maybe come back if they were to need other treatments, those would be available as well.
Yes.
That's fantastic. Tell me a little more about your practice. Are there other conditions that you like to treat? It's really all about gout for you. It sounds like you treat everything in the world of
We
rheumatology,
we
but
actually do.
Mhm.
We do treat people with rheumatoid arthritis where the immune system again has gone bonkers, attacking the joints.
Mhm.
We treat people with inflammation in the eyes, like uveitis. I just have a patient I'm going to see later today who has inflammation in the eyes, which is
Mhm.
due to the immune system kind of attacking the eyes in his case.
Mhm.
We treat people with ankylosing spondylitis. The immune system is
Yes.
attacking the spine.
Mhm.
Psoriasis and psoriatic arthritis, immune system is attacking the skin.
Mhm.
Lupus, where the immune system is attacking the whole body. And
Mhm.
so we also treat people with osteoarthritis, people with osteoporosis, as we talked about, and some
Yes.
people that have like calcium deposits in their joint because of uric acid
Oh
deposits in
yeah.
the joint.
Very good.
And so a lot of people with, yeah, go ahead.
Oh, I was just going to say, here's another interesting referral that we will sometimes make to the rheumatologist is like that patient who has fibromyalgia or maybe thinks they have fibromyalgia, but maybe there's some element of uncertainty and to rule out other conditions. How do you deal with that in your practice? I know there are official criteria from the American College of Rheumatology. I think those are kind of, to my understanding, the best gold standard
Yeah.
criteria. Is that something that you help to diagnose in your practice if people need that?
Yeah, so yeah, when a patient is referred to us for fibromyalgia, our number one goal is to make sure we're not missing anything else,
Yes.
right? So sometimes those patients I've had a patient who we found actually had an autoimmune disease, actually was beginning to develop lupus, right?
Ah,
So one of
mhm.
the things that we do is because a lot of symptoms kind of overlap. There's, I'm aching all over, I'm fatigued,
Yes.
I have brain fog,
Yes.
sometimes I have gastrointestinal issues. So,
Mhm.
we also kind of check and see if there's some element of depression. We check
Mhm.
and see if there's actually sleep apnea, which is kind of our biggest pet peeve.
Yeah.
Because if you're not getting oxygenation into your brain at night, your nerves start to fire and everything hurts, which is what fibromyalgia is.
Yeah.
So we really go very strongly on trying to figure out if they have restless leg syndrome.
Mhm.
So we try to figure out if there's anything else that could be manifesting like fibromyalgia
Right.
before we actually fully give that
Right.
label, because there's no blood test specifically for it.
Right.
So
Yeah,
yeah, it becomes a
technology.
little bit of a soft science. So if we can eliminate things that we can focus on and we can treat those, we may
Mhm.
not be able to get the pain to zero, but we can dramatically improve the quality of life and decrease the intensity of the pain. And I think that's worthwhile.
Absolutely. Yeah, I think that's so helpful. And I can think of another patient that I saw this week who was having pain in her sacroiliac region and had seen the rheumatologist before. And without reading the rheumatologist notes, she tells me, at one point they thought that I had rheumatoid arthritis, now maybe not. Tell us about that. It sounds like she was maybe in that seronegative area where patients have maybe some signs of this particular disease, but not all the signs.
Yeah. Yeah, I mean, that's what keeps rheumatology interesting,
Hmm.
is that the lab tests are helpful, but they're not 100% confirmatory,
Yeah.
right? So you can still have rheumatoid arthritis despite having negative lab tests. What that
Hmm.
means to your rheumatologist is really more that, yes, you may have rheumatoid arthritis, but it's not going to be as severe as if your labs were positive, right? So
Hmm.
it's usually a good thing if your labs are negative. It's lab
Hmm.
tests in our world usually is an indicator of severity, right?
Ah, okay.
Yeah, and sometimes the immune system can be in flux, right?
Right.
Where things kind of start up and gets under control, and then you see a rheumatologist years later, and the other rheumatologist says, I don't see active inflammation, and I'm just like,
Yeah.
good. That means whatever they did worked. Now we're going to focus on what you have going on right now.
Yeah. That's great. Yeah. And I think so often patients are almost just looking for that, I don't know, some support really almost, right? Of validation to a certain degree. Okay, you do have these markers, you do have these symptoms. It is what it is. And not like, oh, you don't have rheumatoid arthritis, go away, but more like, well, you have these markers and here are the treatments for where you are.
I totally agree, and patients don't necessarily present textbook, and so along the line there are different variations. Certain foods or infections can trigger the immune system, so it can look like rheumatoid arthritis, and then it can calm down.
Hmm.
So yeah, we're never 100% fixed on the diagnosis with rheumatology and our
Hmm.
patients. You always kind of have to be thinking as a patient evolves, we have to evolve with our diagnosis.
Yeah, that's so interesting. Yeah, and I think that idea that the immune system can be in flux. Now, could someone have rheumatoid arthritis and then not have it? Does that apply to maybe any of these immune conditions?
Yeah, so certainly things can quote unquote burn out or go into remission,
Hmm.
right? And so so especially children, kids get rheumatoid arthritis too. Babies get rheumatoid arthritis, and actually that form of arthritis actually typically tends to go into remission by the time they become adults. So definitely it's possible for the immune system to kind of correct itself and
Hmm.
stop doing bad things. Yeah.
That's so interesting. Yeah, I think that's so interesting, and just the idea that as right living beings, and our immune system is like that too, and that not
Yeah.
everything is progressive. And um, as a pain doctor, I find myself encouraging patients, right? Like there is hope, there is, things can get better, and so I think it's really encouraging to hear some of that message from you too, that the immune system, not all of the negative changes are totally irreversible or
Yeah.
stuck with them for sure for life. Sometimes we
Yeah.
just don't know.
Yeah. You're right. A lot of people are, always concerned, and a frequent question I get is, am I going to be on this medicine for the rest of my life, right?
Yeah,
And
and how do you answer?
so I guess it really depends on which condition. Some I know, like if a person had a reactive arthritis, I know you're not that where there's it's most likely that your immune system will kind of correct. Some conditions like rheumatoid arthritis is not impossible, and I think I tell my patients that our role is to preserve your joint function and preserve your quality of life so that when your immune system does revert, you don't end up with, oh, it's reverted, but oops, I can't move my wrist, right? So our job is to make sure that your joints are intact, you have an excellent quality of life. We're all living longer and longer, And so we want to have healthy lives and healthy joints.
Yeah, healthy lives. What are your top tips for healthy joints?
Top tips for healthy joints is one, exercise, right?
Okay.
Um, and exercise includes everything from strengthening to stretching, right? So
Mhm.
when you strengthen your muscles, you strengthen the ligaments and tendons, and that actually provides like an additional cushion and protection for your joints,
Mhm.
right? So even people that run marathons, all that, you will notice that the Olympic runners, they strengthen. They
Mhm.
don't just run because you're going to wear down that cartilage. So
Yeah.
strengthening provides that additional support, and that protects your joint. And that, I would say, is the number one thing that will protect you for a long term to come. Other things are diet. With the
Mhm.
exercise, and diet is keeping your weight under control, right? If
Yes.
the BMI is high and the weight is not under control, then you're just grinding that cartilage down, especially hips, knees, and ankles, right?
Right.
So, and then the third thing is diet, right? And so diet also includes things like the anti-inflammatory diet,
Mhm.
right? There's a
Yeah.
broad category called the Mediterranean diet, which I know
Mhm.
Dr. Merritt knows all about. And so I would say those are kind of the top three things that I would recommend to patients to say, hey, if you want three things, if you don't do those things, I think you're going to be in pretty good shape.
Awesome. Awesome. Well, thank you so much, Dr. Dada. I appreciate this so much. And I just enjoy you so much. And I'm pleased that you could be here and share about joints. I think that we've got some excellent pearls for people to listen to. And I've learned things. So I just really appreciate you being here.
Thank you, Dr. Merritt. Love your show. I was really, like I said, I was really enjoying listening to everything this morning. So it was a lot of fun. Thank you for having me.
Yeah, my pleasure. My pleasure. Yeah, so this is Sarah Merritt from Lifestream Health Center in Bowie, Maryland. I've put Dr. Dada's information in the chat here. Please contact her. And if you're looking for pain management in Maryland, call our office, 301-860-0305. We're taking new patients and would love to see you. Thank you.